Good afternoon, ladies and gentlemen, and thank you inviting me to talk on case-based discussion for patient with multiple myeloma. In next 10 minutes, as multiple myeloma has some challenges and solution in 2022, I will use the resources to solve these challenges and to remember to multiple myeloma A to G hits of multiple myeloma. So the basic challenge in multiple myeloma has multiple novel agents. We have more than 20 novel agents and more is coming, but the question is how to sequence these novel agents for our patients. Multiple myeloma is not a one disease, so one size doesn't fit all. Rather than, I would say, multiple myeloma is a marathon, means long-term strategy. It is not a sprint. It is not short-term strategy. So far, 3 decades, we have stratified score like ISS and revised ISS score, but I use these lines from green, which is the very easy patient, to blue, normal patient, and then orange, which the patient which is good but last to follow up is black like this one, and the red line, which is the hardest patient. So I will present all those 4 cases. So first case, which is actually, you can say, blue line, a 58-year male who had history of hypertension with 3-month history of Beckett and on X-ray found lytic lesion. He was referred to our hospital. All the workup was done. You can see here all the things ABC, which we use in ICE score, albumin, beta-2 macroglobulin, LDH, which is very high, and he has also IgG, which is 44, and serum electrophoresis revealed IgG kappa, and his cytogenetics was standard. The bone marrow revealed 30% plasma cell. So we have diagnosis IgG kappa with stage 3 standard risk. So we have now accurate diagnosis staging. So before beginning the treatment, we have to check SLAM CREP, which he has featured. So I will go to treat. Now, next step is C, choose wisely the treatment option. Is my patient is eligible for transplant, ECOG performance 1, and young patient, yes, he is eligible. Now D, choose the drug in frontline multiple myeloma. We are in 2022. We have tons of the options, but this patient was, remember, in 2012. So what we should use, currently we have VRD or DARA-based, VRD-based chemotherapy, but VRD we continuously using as we use in this patient as well. To solve the challenges, there are 3 resources, NCCN. They use also still VRD, DARA plus VRD, or expert online CCO. They also recommended VRD or DARA plus VRD, and then International Myeloma Group also same. So far same. So we are using, since more than decades, VRD I've used in this patient based on SWOG S0777. You can see after 4 cycles, he has PR clinically and laboratorically. The important question, even those days, even till 2022, the patient who are doing great in blue line or green line, is transplantation is still needed or not needed? So can you delay transplant for when disease relapse for second time, as determination trial has shown, the negative MRD is almost equivalent to patient who has gone for transplant. So anyway, this was 2012. He took 8 cycle of VRD, then maintenance lenalidomide. So PFS was almost 3 years. After 3 years, he has disease came back. Now again, to solve the challenge, we have to use the resources. Now you have here, you can use DARA-based chemotherapy, KT-based chemotherapy. Similarly, International Working Group and expert on, they also say DARA, KRD can be used in this patient 2022. But come back in our patient, we were in 2014. So we used Syabort-based chemotherapy. Patient went in complete remission. He went for autologous transplant, and then he took Velcade. Again, he enjoyed 4 years of PFS, and again, his disease came back. Now, he had not a second transplant tissue was available. So we started DARA KD-based chemotherapy, and he has taken 2 years of the Dara-KD-based chemotherapy. So you can say this is journey of my patient, the importance of novel therapy. Over the 10 years, he is doing great. Now, similar blue line of the patient, elderly lady who is actually not candidate of transplant. The story starts about 2008 with the history of Beckett, and again the workup revealed she has all the risk factors of the ISIS poor category, and immunoglobulin was also, it was seen light chain actually 400, and she was diagnosed with IgG kappa light chain multiple myeloma stage 3 and standard risk. So she has also feature of SLIM and GRAP. So now the question is, choose wisely optimum treatment. As we know, we are in evaluation of the MP, RD, then RVD, then Dara Lendax. So we were in 2008. First, we used VRD in this protocol, 3 years PFS, then SABORD, then 4-year PFS. Then she took PD-based chemotherapy, again 3 years PFS. Now she's taking Dara monotherapy. So this is the 1.5 decade journey of this patient. Now I will go third case, which I label this patient as an orange line. This is again 68-year male, known case of asthma, stage 2 ISS category, and he was also in a high risk also. So we planned to, patient will go for autologous transplant. He didn't accept, so he took VRD-based chemotherapy, 8 cycle, then lenalidomide given. I put it orange line because he lost to follow 1.5 years. When he came back, he was very in bad shape. So there are multiple lytic lesions in the vertebrae. So we radiate first over there, and then we started KD-based chemotherapy. And you can say it's now a journey of 5 years, over 3 treatments over there. He's doing great, but he's in orange line. Now, case 4, I would put this as a red line. Why? Because he has 67-year male, and he has history of severe backache, and he has multiple lytic lesion in the vertebrae, and actually he has all the ABCD ISS and revised ISS high score, and cytogenetics was very high risk. So he has IgA kappa multiple myeloma stage 3 high risk category. Now this is the patient actually challenges, because this was now we are in 2021, 2022 era. So first thing is, as I mentioned, he has severe backache. So we radiated him on the back. Once it's done, our plan is either should we give VRD or quadruplet in this patient. So we don't have facility, first line in the hospital. So we started VRD-based, SOVAC-based trial. So here you can see he received 3 cycles of VRD-based chemotherapy. Unfortunately, his disease progressed based on the chemistry and based on also radiology as well. You can say compared with the previous MRI, he developed new compression fracture as well. So what we did, we use now Cantor-based chemotherapy. He has completed 3 cycles of chemotherapy. Now he will go for autologous transplant. So this is red line. Now, 5th patient, typical severe, I would say dark red line. Why dark red line? This is 60-year male. He has 2 problems actually. He has extramedullary disease and plasma cell leukemia. So he has the most aggressive disease. It was diagnosed about 6 years ago. However, he also not able to go because of logistic issue for autologous transplant. So anyway, we started VRD. He was well for 1 year. Then we started POMA KD actually. 2 years he was good. Then he lost to follow up. Then we started Dara KD, and now currently he on Dara KD and cyclophosphamide chemotherapy. So again, I mentioned, this is the beauty of the different novel agent. Over the 6 years, very difficult patient, extramedullary disease and plasma cell leukemia. He has a journey, but it was well taken by all these novel agents. Now, last but not least, green line, which is very easy. This is actually 70-year-old lady. She had history of renal dysfunction. She has mild type of disease, standard cytogenetics. Now the question is what we should do. We could give VD, KD, RD, anything, but renal dysfunction was there, so we avoided unnecessary, Revlimid. So VD was given in this patient. So over the, you can say, 4-year journey, she has taken VD first complete 1.5 year, the VD continuously. Now, over the 2.5 years, she's taking just Velcade every 2 weekly as a maintenance. Over the 4 years of the journey, as I would mention, this is the green line, the most easiest patient. So she's on VD-based chemotherapy. So last 10 minutes, what I wanted to tell you that you have seen, I have used all the resources, NCCN, International Myeloma Group, expert online NCCN guideline. And what we learn that myeloma is a marathon. You have to make a long strategy. If it is green line, you have to go slowly, take simple medication. And if you have blue line, go for a standard, as I mentioned in my all patients. And again, if orange line, if last to follow up here, you can say black last to follow up, then you have to take care of accordingly. But remember, if you have red line, I think quadruplet is the best treatment currently. Currently treatment option. So thank you very much. I am here happy to answer you all of the questions. Thank you very much.